Thank you. So this last presentation is on functional CNS imaging. So the questions that one has when about the central control of the lower urinary tract is what has actually led to advances in functional imaging in the context of understanding bladder dysfunction. And there are several questions that come up. What are the changes that are seen in brain activity with bladder filling? What changes are seen in lower urinary tract dysfunction? Do treatments for lower urinary tract dysfunction reverse these changes? And can these changes be used as an imaging biomarker for dysfunction and its treatment? Sadly, we don't have answers to most of these questions, but it does open up the intrigue and also open it to listeners of this module in regards to future research questions. So to detect changes in the central nervous system, what we're alluding to is essentially brain activity. And this could be detected either by looking for changes in metabolism or blood flow. So you could have a SPECT study, as you can see from this is from the 90s, and then more recently PET studies, and you have functional MRI studies and near-infrared spectroscopy. So different sort of ways to assess these changes in either blood flow or changes in metabolism. Or to detect changes in brain activity, you could look at the changes in electrical activity and magnetic signals. So either like EEGs or magnetoencephalography or MEGs, or looking at even the evoked potentials that you heard earlier is a form of sort of imaging, but looking at electrical signals rather than changes in blood flow or metabolism. Now we focus on just imaging either PET or fMRI today. And the principle in PET studies is that you have an unstable molecule, essentially a tracer that's emitting positrons. For example, you have water that sort of has an O15 isotope, and this is injected. And in the brain, there's a relative increase in blood flow during an experiment, and thereby there's an accumulation of the tracer. So what happens is the positron that's emitted collides with an electron, and there are two gamma rays that are released. So essentially, the patient is lying in a scanner that detects gamma rays, and based on the changes in activity, one gets an idea about essentially a change in metabolism that happens, and that's the signal. Now, when you look at changes in blood flow, it's something different. Now here, there's no radiation. You don't look at metabolism here, but the assumption is that there will be an increased blood flow to brain regions that have a heightened neural activity. So when there's an activation of brain regions, there's an increased activity of neurons, more energy is required, there's greater oxygen consumption. This results in more blood flow, and there's an increase in the regional blood flow as a result, and that hemodynamic response is localized to within 2 or 3 millimeters of the site of that increased neuronal activity. However, the total blood supply varies little between the periods of activity and rest. And the changes in blood flow that occur begin a couple of seconds to around 6 to 10 seconds after that neuronal activity. So how is that used in functional MRI? Is that a larger change in blood flow occurs rather than compared to that of oxygen metabolism. And what you have is an oxygen-rich and poor blood have different magnetic properties. And based on this principle, you have a gradient. And more oxygen if it's more oxygenated, then there's a stronger signal. And so what we look at is for the blood oxygen level dependent effect and in fMRIs, and it's a bold signal change that we look at. Now, nowadays, those of you who follow CNS imaging will realize that actually the preference is for functional MRI. And this is just because of several reasons. One is that there are better infrastructure, so there's more availability of MRI scanners than PET scanners. There's less technical staff that's required, though you do require a competent team for both. If you look at the technique, fMRI is far less invasive, doesn't involve radiation. And if you look at the images from an fMRI, there's greater spatial resolution, as well as temporal resolution as well. And what we look at is the change compared to a resting state, compared to an activity of neurons are happening. So one could perform this change either by pelvic floor muscle contraction and relaxation, so you have the relaxed state and a contracted state, or using paradigms like these, where you could have an infusion of the bladder and then drainage. So you have a change in activity, and this contrast is what's looked at. And this then gives you, following a statistical analysis, you get statistical maps that they'll tell you about the changes of activation. But essentially, the activation is coupled with the hemodynamic response. So what is the role of CNS imaging? So we look at sort of our understanding about lower urinary tract functions in health and disease. And this is probably the area where imaging has provided most of, been of most use. And so this is, so you look at bladder sensations experienced in ordinary life. And the current views of bladder sensations are derived essentially from urodynamic studies. And what you have is a continuing of gradually from one end of not, and then to increasing intensity and pleasantness. You have a first sensation, first desire, and then you have a strong desire to void. So there are a few centers in the world that have advanced the field of and applied fMRIs for understanding bladder functions. And Derek Griffith's work from the University of Pittsburgh has been actually quite in the forefront of this, particularly in understanding bladder sensations. And in this small cohort of healthy elderly women who were undergoing an fMRI study where they had a sort of an infusion sort of a drainage paradigm at low volume filling and mild sensations, consistently there were areas that were being activated in the anterior cingulate cortex, the insula, as you can see here, and also in the periaqueductal grave. In the same cohort with a more volume infused and now a strong desire, you find that there's more activation, particularly anterior cingulate cortex, as well as in the insula, and the activation seen in the insula is actually less diffuse and also shifts more anteriorly. And so these are areas that have consistently been shown to be activated, not only in these studies, but also from studies from other eminent centers where fMRIs and PET studies have been performed. Urgency, of course, is a pathological state where there's a complaint of a sudden compelling desire to pass urine, which is difficult to defer, and it's a defining characteristic of an overactive bladder, and it's often accompanied by detrusor activity in urodynamics. And in imaging studies, what's been demonstrated is that in individuals who demonstrate urgency, but not necessarily detrusor of activity during the studies, there's a weakened response with smaller volumes that are seen. And this becomes exaggerated once the volume infused. If the paradigm is that there's a large volume infusion, you get this exaggerated response that's seen at that point. So this gives you an idea about the areas in the cortex that are involved in the perception of sensations in health and in disease. And based on the wealth of knowledge that's been acquired from different studies, there has now been a working model of lower unit control that is proposed in essentially three circuits of perception of fullness, urgency, and then a third circuit that involves the parahippocampus. And this, therefore, has provided immense insight into our understanding on the central neural control of blood functions. Now, what about understanding what happens following neurological disease? So there are several studies, small studies in Parkinson's disease, but I will focus on small vessel disease. Now, this is a condition that affects the elderly where doesn't present as a stroke, but often presents with a progressive syndrome of urinary incontinence, problems with mobility, and problems with memory. And studies have demonstrated a relationship between white matter changes and urgency incontinence. And in this study from the same group, and Stasatatic was first on this study, looking at sort of the relationship, it was found that in elderly, community-dwelling elderly individuals who were reporting predominantly urinary incontinence but who had significant white matter changes, there were specific areas of regional activation and DV activation that was more prominent and also correlated with the burden of white matter changes. And they found a correlation between these and specific white matter changes in the anterior thalamic radiation. So CNS imaging has therefore helped to understand the pathophysiological basis of blood dysfunction in specific neurological disorders. Now we move on into the clinical utility, which is the third part of this presentation. And this is where there is still work that's required because we don't fully understand the relationship between what we see with what happens in health and particularly in disease. And because these changes are representing changes in neuronal activation or activity, and we see patterns of activation and deactivation, but really we don't entirely know what this means. And also the studies are highly dependent on the details of the paradigm that's been used, the design of the study, and most importantly, the method of analysis and the statistics that have been used. So what is the role in clinical practice? And this is really what the future is about. Currently, to be honest with you, the translation into clinical practice is limited. But there are questions to be asked. Can patterns of neural activity in the brain identified during functional imaging paradigms be developed as a biomarker for urgency or for the overactive bladder? Are there different patterns of neural activation in patients presenting with the urinary urgency incontinence phenotype? And can the imaging changes be used to better understand the mechanisms of intervention for managing urinary incontinence? So from Derek Griffith's lab, Becky Clarkson demonstrated that there are actually different patterns of brain activation that are seen in people who respond to pelvic floor muscle training compared to those who don't. So could this be used as a predictor of response? Rose Carberry from Baylor has demonstrated changes in neural activity following detrusor injections of botulinum toxin. So all quite preliminary. And so I think this is an area that is really requiring research, but certainly provides potentially a biomarker for disease for future studies. Thank you very much.
Jalish, can I ask a question, please?
Yeah.
So, Jalish, this is very exciting, and we have been following this up for some time now. But if you think in the last, Derek's work was in 2007, so it's coming to about 15 years. So, do you think that it will evolve into one of the investigations we do as a clinical practice, or it will remain experimental? And if it is incorporated into clinical practice, will it replace urodynamics or it will become complementary?
So I will answer the second part of that question first. I don't think this will ever replace urodynamics. It's like comparing apples and pears. Urodynamics tells you about bladder functions. This will tell you about the brain correlates. The utility, I think, partly is because these are all done in MRI machines, which are not away, or probably the other end of the hospital of the urology department. I think the future would be something that could be performed in the urodynamic suite itself, such as a near-infrared spectroscopy. The limitation of NIRS is that it doesn't provide you information about in-depth sort of changes in activation, but certainly will provide you cortical changes, particularly the frontal cortex, which is involved. So I think that is where probably the future will be. And I think what is essential would be to have a standardized paradigm that's used across different centers. I think also, particularly the work from Bertolt Bloch's group now looking at high resolution MRI with 7 Tesla will provide you more a nuanced approach in identifying a center in the brain, which could be used as sort of a center for the biomarker. But this is all work for the future, Rizwan.
Thank you.
Jalish, what about spinal fMRI or spectroscopy?
Well, I intentionally left that out because I think that's even more exciting than brain. And so spinal fMRI is just coming up in a big way. And I think what will be exciting would be looking at changes in the sacral spinal cord. Currently, the spinal fMRI studies are all at the level of the cervical cord, but once it moves down to the sacral cord, particularly the gray matter, it'll give you information about what's happening in the gray matter of the spinal cord, which is where your parasympathetic nucleus that innervates the detrusor. And I think particularly in patients with diffuse underactivity, this is going to be a very useful tool, of course, in the future. Spectroscopy, I'm not so sure. I think it'll tell you about metabolic changes happening in the neurons, but beyond that, I'm not entirely confident that it is going to be a game changer, at least in neurourology.
Tractography.
Yes, I've seen that question. So the question from Jane was, you talked about OAB urgency. To what extent could this apply to sensory painful urgency? And I agree that there is quite a bit of research actually into the painful and into bladder pain syndrome and understanding the neural correlates. I think it also opens up a question: what we're seeing. We see neuronal activation. It's just groups of neurons that have become active, and you see the hemodynamic response. So is it actually a correlate to a sensory signal, or is it the processing of that and additional areas? For example, the emotional component of pain or the emotional component of urgency. Is that what this correlates to? So I think there is a future for painful urgency and bladder pain. But I think how it relates to the patient's clinical symptoms is something that needs to be further understood if we're going to make sense of it and if it's going to become a clinical tool.
I have a question for the precedent presentation about what you told about the evoked potential after stimulation, electrical stimulation of the urethra and the mucosa. My opinion is that it is very difficult to record any potential from the detrusor, because you always stimulated both C and R delta fibers. So, and in neurogenic bladder, you know that mainly the afferent change to C fibers. So how maybe you enable to differentiate between evoked potential after stimulation of C fiber or evoked potential after stimulation of R delta fibers?
So this is, I would say it's probably a limit of my understanding, but the evoked potentials are essentially going to be following stimulation of the large fibers. And so, and I can only say that with a small fiber that's being stimulated, the latency is going to be longer. So I wonder, and this is, I have no personal experience with intravesical stimulation, but I wonder whether what you have is a more broadened peak, because you would have the faster conducting fibers and the stimulus arriving and being recorded from the scalp, and then later on you have from the C fibers and A delta. But it's
so
not
difference in latency probably.
Yeah, probably so. Yes.
So I don't see any question of the floor. So I propose we are on time, Roger, I suppose, Rob. Yeah, I will just make a summary of the study of the session. So today we have the occasion of discussing different diagnosis method, from the one presented by Rizwan Almid on urodynamic and video urodynamic. We share his experience on the utility and the limitation of the technique. I try to explain you qualitative EMG, what is the role during avoiding cystomanometry, and especially in spinal cord injury, and what are the limitations. We also speak about vegetative testing, which are difficult to perform, except perhaps for the Dartos reflex, which is clinically easy to induce and reproduce. The other one are more reserved for research purposes. And Jalek explain you us in detail all electrophysiological method you can use for diagnostic neurogenic bladder, pointing at the fact that bulbocavernosus reflex and EMG from the external and anal sphincter are the mostly used, evo potential remaining mainly for research purpose or for peripheral disease. And at least Jalesh present a nice talk on MRI and imaging study with very fascinating results on fMRI. And we also discuss the utility of the technique and the future of new method of neuroimaging. So I want to thank you all for being present, and I want to thank Jalesh, I want to thank Rizwan, and I want to thank Rob and Roger for helping us to prepare this session. And I hope to see you live in a few time, and wish you and stay safe and healthy. Bye bye.